Guys, we're in the middle of a pandemic and these are trying times. It's hard on our mental health, our mental state, and this is why I love our sponsor today, BetterHelp. They're the largest online counseling platform worldwide. They change the way people get help with facing life's challenges by providing convenient, discreet, affordable access to licensed therapists. BetterHelp makes professional counseling available anytime, anywhere, through a computer, tablet, or smartphone. It's brilliant. Sign up today. Go to betterhelp.com/solvinghealthcare and get 10% off sign-up fees.
COVID has affected us all, and with all the negativity surrounding it, it's often hard to find the positive. One of the blessings it has given us is the opportunity to build an avenue for creating change, starting right here in our community. Discussing topics that affect us most, such as racism in healthcare, maintaining a positive mindset, creating change, the importance of advocacy, and the many lessons we have all learned from COVID. If you or your organization are interested in speaking engagements, send a message to quadcast99@gmail.com, reach out on Facebook at Quadcast, or online at drkwadwo.ca.
Welcome to Solving Healthcare. I'm Kwadwo Kyeremanteng. I'm an ICU and palliative care physician here in Ottawa and the founder of Resource Optimization Network. We are on a mission to transform healthcare in Canada. I'm going to talk with physicians, nurses, administrators, patients and their families because inefficiencies, overwork, and overcrowding affects us all. I believe it's time for a better healthcare system that's more cost-effective, dignified, and just for everyone involved. Welcome, everybody, back to Solving Healthcare, Quadcast Nation. We have the one and only Dr. Martha Fulford back. She's an infectious disease specialist, works in Children's Hospital, and our number one downloaded episode, actually, I don't know if you know this, but our episode on childhood vaccines was our numbers quadrupled. I've never seen anything like that. So we had to bring it back. And I'll tell you why, people. I've never had so many questions. So we were very happy personally in our household that school's back tomorrow, January 17th. But I was actually quite shocked at the number of parents that were anxious. Like, I shouldn't say shocked, but there was a lot of anxiety around bringing kids back to school. And I thought, why not bring Martha back to answer some of these questions? And many questions that have come across over the last 3 or 4 days since we publicized this episode. And so, yeah, we're just going to try and answer as many as we can that were forwarded along to us. Before starting, I just want to give a quick plug to our Solving Wellness program, which is continuing to make a dent in burnout amongst our healthcare professionals, where we offer workouts, yoga sessions, mindful meditation, nutrition tips, cooking classes, and it's all to mitigate burnout amongst our healthcare providers. And it's a great community. We're up to 300 members. If you press NL into your chat box, you'll get access to our newsletter and access to this show, and also some of this content from Solving Wellness that we put out on our newsletter. So put in NL into the chat box and you'll be up to date with everything Solving Healthcare and Solving Wellness. Okay, so Martha, we'll jump right into it. I get this question all the time when I do mainstream media. Are we doing enough to keep schools safe? Are we doing enough to bring the kids back? In your humble opinion, are schools safe?
This is always a challenging question because I don't think they were ever unsafe. And it's a really interesting narrative in Ontario that we start from the presumption that somehow schools were inherently unsafe to start with, because it's really difficult. I mean, how can anybody object to the question, are schools safe? But if they weren't unsafe in the first place, it becomes really difficult to try to take us back to that position. But clearly, right now, are they, do people need to worry about COVID and kids if they go back to school is really the question, right? And I always sort of think, okay, so was there anything different in Ontario and in our schools than other schools in Canada or internationally? And that's really what I think what we're asking. So are kids more likely to get COVID if they're in school than if they're not at school? And overall, from what we've seen in Ontario, in Canada, and really around the world, is that schools have not been the most common site for kids to get COVID. They actually are more likely to get it when they're out and about interacting with family, doing that kind of event. And it's because COVID, for whatever reason, which is a bit different than some viruses, is more likely to be transmitted by an adult to a child. This may change with Omicron, but we certainly haven't seen that yet. Because, of course, children don't go into a black hole when they're at school. They're still out and about. And if you think about it, in Ontario, kids aren't at school, and we're still seeing lots of COVID. And so it's that context or that perspective. So for me, I'm not worried about a child going to a school with the perspective of COVID. This has not been where we've seen it. It has been community first and then into the schools. Mm-hmm. And I'm going to also push back a little bit, because what does safety mean when we talk about safety? Because safety is not just no COVID. Safety is everything else. It's the mental health. It's the physical health. It's the access to exercise. It's the eyes of the adults on the children who might be subject to abuse. It's all of those other things that are part of safety for our kids. And so to me, it really, if the only thing we're asking is COVID, it really, to me, narrows the conversation in a way that does not do justice to our children in terms of what they need. So it's a little bit of a broad answer, but more specifically, Ontario's had its schools closed. We have had the longest school closures anywhere in all of North America. This is not a point of pride. We can look at schools in other jurisdictions. We look at schools in British Columbia. We can look at schools in other parts of Canada. But more important, we can look at schools in Europe. We can look at schools in the United States, which have not closed at all or had significantly shorter closures. So we can look around and realize, actually, when the schools are open and the kids are going to school, nothing bad happens to the kids in terms of COVID, but they don't have all the collateral damage from the social isolation and the online learning and all those interruptions that they've been subjected to here.
No, I think that's very well put. And then one other area, like pre-Omicron anyway, like we weren't seeing as much secondary infections, like secondary spread within schools. Like for whatever reason, I got this question. I got this question on a previous interview. And she's like, how is this possible that, like every other virus, it seems to spread like wildfire within kids? But this is one of those things, as I've heard you say a number of times, Martha, it's like one of the miraculous things about COVID is that it just doesn't seem to affect kids in the same way it does adults. Yeah.
And this has always been, to me, something I don't understand. We haven't celebrated more. March of 2020, when the, we first sort of kind of acknowledged there's a pandemic and there was the first closures. It was very rapidly obvious by about May of that year. So May of 2020, looking around the world, it was very clear that the group of people that were not dying or being affected by COVID were young people. And despite the fact that even 2 years in now, we still have unequivocal evidence that this is a virus that selectively harms, really in terms of the direct impact, people who are older, and people who have a lot of very well-recognized risk factors now, and we've talked about them before: obesity, poorly controlled diabetes, poorly controlled hypertension. These are metabolic disorders, are the things that we can almost guarantee if that person gets COVID, they're going to have a much more difficult course. And we have consistently seen from in Canada around the world that the group that does not land in hospital with any frequency at all because of COVID are young people. And yet we're still not, it's almost like we just don't believe that there's a good news story with COVID. And to me, this has always been one of the most amazing things, that our children were spared.
Yeah, I had that question posed today too, like in terms of, just like celebrating the idea that kids aren't as affected similar to adults, especially when we know the risk factors. Like it was like I had to frame it in the interview. I said, literally, I have no anxiety about my kids going to school. I'm happy that our kids are going to school. Yeah. And I think a lot of people have a tough time wrapping their head around that. And I think also, Martha, and I think a lot of it stems from a lot of people thinking that we could still avoid COVID. Like maybe you could comment on the idea that, this COVID zero, or the fact that, initially we're trying to avoid COVID at all costs pretty much. But at this stage, this really isn't possible.
No, I actually never thought it was possible. I was one of the people going, COVID zero, that's like a fantasy. In the history of the viruses, of human viruses, we've eradicated a grand total of one, and that's smallpox. And there are very unique features of smallpox that allowed that to happen. It had a very distinct physical, like a characteristic appearance when people got smallpox, with these unmistakable skin lesions. People were really only infectious once the pox appeared, so you didn't have pre-symptomatic transmission. We had a vaccine that actually stopped transmission, and because it was very characteristic, you do this concept called ring vaccination around wherever there's an outbreak and stop it from propagating. And there was no animal reservoir, so there was no. It wasn't a virus that went from humans to animals back to humans. And COVID and respiratory infections met none of these criteria. And so COVID zero always seemed a really unusual thing to aim for, as in unrealistic. And unfortunately, I think it actually did a lot of harm, because people have the wrong expectation. Then they're going to be disappointed and angry and want that. And some of us, myself and other people, were saying, actually, what our aim should have been is not zero COVID, but as close to zero mortality as possible. And so if people are happy with the fact that we have reached a state where the severity of COVID is dramatically reduced, and essentially we're down to what we would expect from any other circulating coronavirus, then we are at a steady state. We've transitioned to what would be considered pandemic to endemic. And an endemic state is not a bad state to be. It means that as we've lived for millennia with viruses, we'll have seasonal variations, but it won't be this huge sort of mass of infections all at the same time on a population that has no underlying immunity. So even today, compared to 2 years ago, we have a significant amount of population immunity. We have very, very high vaccine rates. And though we don't talk about it here very much, certainly if you're in Europe, we would talk about it. People who've had COVID and recovered also have good immunity. So between, post-infection immunity and vaccination rates, the threat is just not the same. People will get COVID, yes. I believe all of us will get COVID at some point in time, but it's not the end of the world. Actually, there's a headline I saw earlier this month. I think it was the 4th of January, from Global News. And the headline literally said, cough, cold, or COVID-19. How can you tell the difference? And I'm thinking, you know what? If you can't tell the difference, you have a cold. And that's really, the mindset. It's a psychological shift. This is not the same thing we were dealing with 2 years ago. And how do we convince people that what we're seeing clinically today is simply not the same? I mean, there are a great many people now who have had Omicron just in the last month. I think all of us know people who've been testing positive or who might be at home for a few days. And part of what we should be asking, if you know somebody who's had COVID, is how sick were you? And if you weren't very sick and if you're just home for a few days, that's okay. I mean, that is sort of a state where we're winning hugely, because most of us will get COVID and we'll either not have any idea at all, or we'll be home with a cold or a flu-like illness for a few days. And it's, is that acceptable or not acceptable? And I think that's a decision we have to make. Some countries have already agreed, this is it. We're endemic, and other countries are not quite there yet, like us.
Yeah, it does. Omicron seemed to enlighten a lot of folks, actually. And I think this might be one of those things where we are forced to change policy, or I shouldn't say forced to change policy. We will change our approach, because those that were not seeing COVID, those that weren't having any exposure to COVID, are now seeing it, and now seeing that, it is not as it always appears, like on the media, like in where, I saw a poll where some folks asked, what were your risk of being hospitalized if you contracted COVID? And numbers would be like upwards to 50%, and I really think that, having this perspective now of knowing someone or of having COVID yourself, I think hopefully we'll see some more policies moving towards it, like an endemic approach.
There was something else I noticed that actually bothered me a lot. Some people were, and you may have seen this also clinically, people were almost apologizing for getting COVID as if it was somehow shameful. And it's not, it's a respiratory virus. Nobody should be ashamed because they got a virus. I mean, these things are, they have evolved for a very long time to, cause these mild illnesses, and it's nothing to be ashamed of. It's nothing terrible. In fact, the repeated exposure to respiratory viruses are one of the things that actually helps build up our immunity so we don't get very sick from them. Mm-hmm. And so we actually have a degree of underlying immunity all the time. So with ongoing re-exposures to these viruses, we don't get that sick. It's nothing, I worry when somebody apologizes they got COVID. I'm thinking, it wasn't your fault. It's a respiratory virus.
Yeah.
There's no shame in getting a cold.
Yeah, no, there's a lot of that going on Twitter right now. I did everything right. I still got COVID. I mean, that's the reality of this thing. You shouldn't be ashamed. Getting back a little bit to the school related questions. So, there's was a movement to make sure that we have enough, for example, HEPA filters in the classroom. Do you have any thoughts on this? Yes, we've mentioned there's no clear signs that schools were unsafe in the first place, but this question comes up all the time. Like, do we need the HEPA filters? How many do we need? Do we need 17? I'm answering this question or editorializing it a little bit. Sorry. But what are your thoughts on that?
I have no studies that they're necessary. And I always worry about people coming up with, you have to have this, you have to have that. I'm thinking, will HEPA filter do harm? Probably not. Now, as you know, from being in hospital, some HEPA filters are extremely noisy. And so if you end up putting a device in a classroom that may or may not make a difference depending on the size and, how many people are in the room and where it's positioned and all of these things, and it's very, very noisy and all it ends up doing is causing disruption, and again, it's the pros and cons of something. But I will say that, I think one thing that's been highlighted throughout all of this is that a lot of our schools are old. And really not great facilities. And so whether or not some of these improvements are necessary because of COVID and the fact that schools in most parts of the world, or not, I shouldn't say most, but a great many countries have kept their schools open, would argue that for COVID in particular, maybe they're not necessary. But that's not to say that it's not a lesson learned that our teachers and children actually maybe do deserve to be in really good facilities. One of my patients who's a teacher was telling me that, when the soap ran out in the washrooms halfway through the month, it didn't get replaced to the end of the month. I mean, I think little anecdotes like that are clearly unacceptable. And so working towards the best possible facilities for our children and for the teachers is clearly a desirable thing to do. But do we not let children into school while we work for that? Well, obviously, that's not the right answer either. And so, with the HEPA filters, in general, should we have good filtration, good air in schools? I think that's a good idea. Mm-hmm. It might help with allergies, with, sort of the sick building syndrome. It may actually help with other respiratory viruses. We don't know. So I'm not sure that we know the answers to whether they're going to help because it's not actually been studied in a school. I haven't seen any trials looking at HEPA filters in one class or not another. And so asking for improved environment, I don't have a problem asking for that, but I have a problem if it's used as a barrier to not letting schools reopen. And this is what worries me about some of these conversations is people are asking for improvements, which is not an unreasonable thing to ask for when it comes to the air quality. And we're just on air quality here. And that's not a bad thing to ask for. It's not a bad thing to say that, our children deserve to be taught in school, in buildings that are actually comfortable and conducive to learning. And I think that's a good thing to aim for, but that doesn't mean our kids can't go back now. And this is, again, one of those balancing acts because we don't know if HEPA filters make 1 iota of difference, but more to the point, we have not seen children harmed anywhere when they do go back to school from the COVID perspective. And I will come back to this over and over again.
Please
Ontario is not an isolated island with nobody they can look to information. We can look, for example, to all of Scandinavia. We can look to countries where schools have not been closed at all, where none of these measures have been put in place. Classrooms are normal. There have been no masks in the classrooms. They all have lunch together. They all play together. They all have the same games and sports and extracurriculars which are not canceled. And those kids are fine. And if they're fine in Scandinavia, and if they're fine in 50% of the US, and if they're fine in the United Kingdom, they're going to be fine in Ontario.
Yeah, please preach this. And I agree with you wholeheartedly. Like, this shouldn't be prohibitive. And I gotta say, one of the things that came front of mind when you were mentioning that, like, Ontario's not unique. And when I hear, like, I get get these letters saying, hey, you know what? Kids are only allowed to speak for 10 minutes at lunchtime. No, they're not allowed to speak for the first 10 minutes in lunchtime. We got silent lunch periods. I've seen these messages that kids are too nervous to drink their water. So they're having to drink their water quickly and all this stuff. Like, all this anxiety provoking stuff is insane. I'm sorry, I'm going to editorialize. This is insane. This is our kids. We know the risk. Ontario, we're not unique. Plenty of places in the world have been dealing with this. And why do we have different standards? Why do we think we need to go above and beyond everywhere else, have longer school closures, higher, like, the other thing of this is, like, there's so many unintended consequences that we just don't appreciate. Like, all these interventions, they're not benign. Like, we assume they're benign. And so it just drives me nuts when people are basing all these decisions not on science, not on data, but it's fear. It's fear-based, anxiety-based decision-making. Yeah. And it's enough. We're January.
Yeah, it's 2 years. It's not based on any data, unfortunately. I actually think, can you imagine 4 years ago if we had said small children are not allowed to talk to each other, they're not allowed to play, they're not allowed to have any contact, they're not allowed to talk to their teachers, they have to eat outside, they are not allowed to have any activities. That would be child abuse. That would have been child abuse. If we had said we are going to socially isolate our children, we're not going to let them play, we're not going to let them eat lunch, we're not going to let them see anybody smile at them, that would have been unthinkable. And we are just accepting this in Ontario, where it's actually not the standard of practice in this world to mask young children, for example. We're doing it here, but most places that have masking in schools is from 12 and up. It's not a standard to do this. And despite the fact that we're doing this here, and so a lot of what we're doing to our children is profoundly harmful to their mental health, to their well-being, to their socialization. I was talking to a friend of mine who was at a parent-teacher meeting for her 4-year-old. And apparently one of the criticisms was that he's not maintaining the 2-meter distance. He keeps trying to play with his friends. And that was a criticism of a 4-year-old who just wants to play with his friends. The criticism to me is, what are we doing to these kids that we're saying they can't play with each other? This is wrong. It is profoundly wrong that this is the message. Telling a child that they're not allowed to talk while they eat lunch, this is not based on any evidence. It's I don't even know where it comes from that we're doing this to our children. Adults are allowed to eat together. We do it all the time. ICU, we do it all the time, and we treat COVID patients. I know. This is what I keep thinking. I'm going, the people who are actually treating patients with COVID, you get a sense, not that you're blasé, but you realize that we can balance our what we're doing, and we have an understanding that it's, most of us are going to be fine. I work at a children's hospital. We're not swamped with COVID patients. We're swamped with collateral damage. Yeah. And it's hard for me to believe that if people are saying we want our kids safe, that somehow the word safe has come to mean no talking, no playing, no interaction, social isolation. I've heard some preposterous things like, oh, well, the kids can all eat outside. They have 15 minutes outside. I'm going, what? We would not do that to anybody normally.
Or
But
to
our
our
young
dogs.
kids, but our young kids, somehow this is what we're saying is okay for something that is not a threat to them. And this is the mind-boggling part of it. This is a fear of COVID, a fear of something that is simply not a threat to our children. Are there going to be a very small number of cases? Of course. But the risk perception is completely skewed. In Canada, I think if you look at all of the deaths in 19 and under in Canada with or from COVID, so we don't know why they died, but 19 and under, since the very beginning of the pandemic, there have been 20 deaths of people under the age of 20 who have had a positive COVID test. When we look at the analysis of deaths, it's usually about 40% are actually because of COVID, and the others that it was incidental. So maybe 10. But in 2018, there are 179 children that died in a car accident. And nobody thinks twice about getting in a car. I mean, those numbers are available in stats. Anybody can look up fatality rates if you want sort of comparisons of risk. If you look at the risks in the United States for 1 to 4-year-olds, a 1 to 4-year-old is more likely to die of suffocation than of COVID. And these are the CDC stats. Again, anybody can go online and look up these numbers. And so the perception of risk, and it's not to say we ignore COVID. It's not to say that we don't pay close attention to adults. This isn't an either or. It's recognizing this is the group of people who are at risk. This is the group of people that we need to pay attention to. We need to focus in on everything we can do to prevent that person landing in hospital, which are vulnerable adults. But it's also recognizing and being honest about the fact that this is not what's going to happen to our kids, but making a 4 or 5-year-old eat isolated, not being allowed to talk, being constantly told he or she can't show her face to anybody. They're not. This is wrong. This before COVID, this would have been frank child abuse, and I don't think anybody would argue that point.
And thank you, Martha. Like, it's just a lot of us, and I know, Martha, you've gotten heat for what we say.
Oh, yeah.
And the hate letters, and what's insane is just that when you look at the risk. Like, I want everyone to understand this wholeheartedly. You driving your kid to their basketball practice or to whatever activity you're doing is a higher risk activity than if the chances of them dying from COVID. Legit. Yeah. And you get into that car, you don't even think about it. So you can't sit here telling me our schools aren't safe enough. Schools ain't safe enough. I'm like, show me the data. What's the rationale at this point? It's not just COVID we got to deal with. We got to deal with the sequelae. You know what I'm saying? By our policies and how it's going to affect them, not just now, but also long term. And we're ignoring this. And I've been saying this for a while. Like, this is the line in the sand for me is the kids. Yeah. I don't like, this is the line in the sand. Okay. Like, if we can't stick up for these guys, who can we stick up for? Because they have just been onslaughted over the last 2 years. We've heard Adrian Matheson, a child psychologist, talking about how their cases have gone, like the anxiety, depression, eating disorders, all man impacted, obesity, type 2 diabetes in our kids going up, child abuse. And we're sitting there saying it's okay. No, enough is enough. I'm sorry. And one other thing I got to get on my chest while I'm rolling. I get these letters also listen, I love teachers. I love you all. Listen, but when I get these letters saying, oh, will you come in and help us out during lunchtime or help us out during during their break and see how you feel or how you feel about the threat of COVID. I'm like, I work in an ICU. I will gladly step into that lunchroom. I will gladly step in and help those kids, whatever you want. You know what I'm saying? Because I know my risk. I protected myself. I'm vaccinated. That's the way this works. Yeah. Step up. It's a time of dignity or duty right now. Sorry, I'm getting all jazzed up here.
Sometimes I think, am I the only person left that actually thinks the vaccines work? No. Because the main role of the vaccine, and I have been vaccinating in clinics over and above my regular work since February, and is by making that decision to be vaccinated, I know that when I get COVID, and I'm saying when, my chances of having a severe outcome are dramatically reduced.
Exactly.
I also believe that I exercise, I try to keep my weight normal, I try to make sure I'm healthy, I do all those preventive things that are also good, not just prevention of COVID, but all those that's my plug for general health, right?
Yes.
But I don't mind who's around me. I can be exposed to COVID by somebody who's been vaccinated and shedding virus. I can be surrounded by people who are unvaccinated shedding virus. The protection I get is the same. So am I worried? No, I fundamentally believe that they work. I don't have to have every single person around me vaccinated or not vaccinated, because that's not how it works. I mean, once you're protected, you're protected. That's
a very good point that I don't think is registered for people.
Yeah. A lot of people seem to think that, everybody around you has to be vaccinated. Well, that's not how it works. There's the personal benefit of being vaccinated stays no matter what. The more people we have that are vaccinated, particularly in the vulnerable adults, there's a public health benefit to that, because that reduces the risk of a burden to our hospitals. That, of course, is most important with people who are going to land in hospital in the first place. It's way less important with younger people, where that's not our hospital burden. So it's less of a concern, obviously, for the people who are at risk in the first place. But our focus on vaccinating vulnerable adults was and remains important. But that, if it's okay. I mean, people want to know, would I go into a lunchroom or a classroom with 30 kids? You do. I mean, I work at a children's hospital, surrounded by kids all the time. Mm-hmm. I have no concerns at all.
Yeah. I mean, I feel the same way. Like, I know I got my protection, especially when as you mentioned, like the transmission data, we were hoping it would be more potent that in terms of reducing transmission. But I think especially, with Delta further down the road from vaccination, but certainly with Omicron, that seems to be less of an issue.
Yeah, I think it's disappointing. We did see some reduction in transmission with the Delta for the first maybe 4 or 5 months after vaccination. Then we did start to see a lot more breakthrough. With Omicron, it really has changed the conversation. We're not seeing anywhere near the same prevention of transmission, but we are still seeing protection against severe disease. And to me, that's always been the single most important component of all of this.
100%. So just a couple of questions that I know that a lot of parents are asking about, just like, if they hearing this and they're still like, you know what, I don't care. I want to try and aim. I want to protect everything as much as we can. There's a lot of question about, does my kid need to have an N95 mask? What are your thoughts on that going to school?
N95 masks are, considered medical devices in a lot of ways. And so when we use one in a hospital, it is properly fit tested to our faces, which means that we try different masks to make sure that we can maintain that entire seal the whole time. We wear them usually for very limited controlled encounters. So if I'm going into a room, say with somebody with active pulmonary tuberculosis, and I know that that's an infection spread, it's an airborne transmission, I will make sure that I find the right mask that I have been properly fit tested to. I put it on before I go into the room. I make sure I've got my seal maintained, and then I keep that seal on in the room. If we're talking about wearing this kind of a mask out and about, I am highly skeptical, to be perfectly honest. There has been no, as far as I'm aware, and if somebody can try to show me, there has been no study anywhere ever that has looked at N95s on children. There are no formal approvals for N95s in children. That's not a standard we would use. But more to the point, there's no conceivable way that anybody, or a child in particular, is going to be wearing one and having a seal and not touching it and moving it around and playing with it. And also, as soon as they leave the school and it's off, they're going to get exposed to Omicron anyway. Not to be harsh, but that's the reality we're facing. And so we're having this conversation in Ontario, and I'm going to come back to the fact that if you're in Europe, no child under the age of 12 needs to wear a mask. And so I still find myself, really quite flabbergasted that anybody would even contemplate that a small child needs an N95 to protect that child against a virus that really isn't a threat to that child. And yet they're actually not recommended for children under the age of 12 if you go to Europe. So again, I think we have to reconcile this in our head. Like, why are we recommending this here? A somewhat punitive measure, actually. It's inhibiting, it's uncomfortable, it's unnecessary. We don't actually know if it'll work, but I guess if somebody wants to run a trial, they could. But I actually think if we're going to be, 2 years into this, if we're going to be recommending something like that, we should actually have evidence that works, it makes a difference, and that it's necessary. Mm-hmm. And I find myself again struggling. I actually yesterday, because I'm working on this presentation, I just I went online and started to search for images of children in school right now, like 2021, 2022. I was just going sports, lunch, dance, music. And it's amazing, if you do that, you'll find all of these images of all of these schools where the kids are just back to normal. They're not being inhibited like this. You'll get, pictures or short videos of kids like in North Dakota with a huge band practice, all indoors, all the kids playing their music and all the parents clapping, nobody with a mask on, because they've decided that it's not necessary anymore because they're comfortable that it's reached an endemic state. You can get, pictures of kids in Ireland or Scotland or the UK playing games. You can get, the kids all running in classrooms and kids on the floor playing games. You can get kids in costumes. There's one from the UK with young kids with Red Nose Day, and they're all wearing little red noses. So if kids in the rest of Europe and in great parts of North America can do that, and this is right now while Omicron is surging, why are we asking our kids to wear an N95? I mean, there should be cognitive dissonance. People should be thinking, hold on a minute. Like, why has Sweden never had a child wear a mask and their kids are okay? And why are we doing this to our kids here? If you look up I think there's 7 countries that are recommending masking in young kids, and no other country is.
Keep asking these good questions. Like this is exactly it. This is part of the this is what makes this so challenging when you see what's happening elsewhere.
Yeah, and it's hard because if I say stuff like that, I will get messages saying I'm trying to harm children, that I must hate kids, and I'm going, no, I don't. I'm actually passionate about the health and well-being of our children. I feel very strongly about what we need to do to keep them healthy, and I'm saying that if we care about our kids, if we really care about our kids and we really care about their safety, then we are going to look after their physical, their mental, their social well-being. We're going to think about their futures. We're going to stop doing things that are deliberately cruel, like the casual cruelty of saying to a child that they can't talk to their friends during lunchtime. That is not based on any medical evidence.
Yeah,
I can't defend it.
I would say
it's actually anti-evidence. Yeah, I have to agree with you.
Oh man, it's just the more I think about this, the more insane I think how we've approached this in so many ways. So a lot of questions come up, like a lot of stuff in the press about higher hospitalization rates in our kids these days. Any thoughts on that? Or even like what you're seeing at your hospital? Oh,
no, we see a lot of incidentals. And the thing is, you have to remember that every person who is admitted to hospital right now gets tested for COVID. We're screening everybody, which is another question. Is I think at some point we need to stop doing that. So if people have no symptoms, we really, if a person's healthy, they're healthy. We need to stop testing healthy people. That's a whole different topic. So every child that gets admitted to hospital is screened. And so when you have a lot of cases in the community, it's not surprising that a proportion of the people coming into hospital will have a positive test. Actually, there's a Public Health Agency of Canada. There's a group called CNISP. It's the Canadian Nosocomial Infection Surveillance Program. Nosocomial means they're hospital acquired. But we look at infections in hospital, and this report is as of December 13th, and certainly from what I saw on the ground, it's no different. But the majority of patients hospitalized are not actually because of COVID. So in this particular review, 60%, actually 56% were incidental. Interestingly, 20% of the kids that tested positive for COVID had zero symptoms. Mm-hmm. So one in five of our positives didn't even have any symptoms of COVID. And the vast majority who don't do well with COVID or who do end up in an intensive care unit are very vulnerable children to start with. They have significant neurological disorders. They're already dependent for a lot of their care. We have children who are in home breathing machines, home ventilators, home oxygen. And these kids are always very vulnerable to any virus, mm-hmm. and not surprisingly COVID. But otherwise, COVID right now, particularly the Omicron, it's no different than any virus. When I was on service all of November, we saw way more RSV than we saw COVID.
So, like, is it fair to say, like, say if you were to compare admissions overall, just overall admissions from this time of year compared to, say, 2 years ago, 3 years ago, would you think there's much of a difference? Just curious.
We may be seeing fewer respiratory tract infections. November felt kind of normal, mm-hmm. With all the RSV. So we had a lot of RSV, a lot of enterovirus. We were seeing parainfluenza 3. We had a couple of cases of influenza, and a couple of cases of COVID that where the kids had sort of exacerbating a bit of asthma. But mostly the kids with the COVID had the significant associated risk factors. So November felt more normal, but mostly because I think the RSV. January, we haven't seen a lot, actually. I mean, some places are reporting more, but I think if you ask around and if you look to sort of across the board, the general consensus from all the pediatric hospitals is that, yes, there are more kids testing positive, but they're not sicker. A lot incidental. One report I read from San Francisco said that 70% of the kids were actually incidental, where that's not why they were in hospital. Mm. And again, how do you balance this? Because you never want to minimize the fact that some children, a very small number, will get very sick, but no more so with COVID than we see with other respiratory viruses that we see every single year. And again, it's all about expectations. And I'm always surprised. I've had people who are symptomatic or their kid has a cold and we say, oh no, it's RSV, not COVID. And they're relieved. I'm going, I don't know. I mean, it's actually RSV is worse than COVID, but somehow they're relieved that it's not COVID.
Yeah.
It's just very bizarre, the fear of COVID. And I think some of the stigma that some people still feel about it. And I keep saying it's just a virus.
Mm-hmm. Yeah.
As in, nobody should ever be ashamed because they got a viral infection. That's just, no, don't. This is not anything to do with behavior. This is the virus being the virus.
No, thank you for that, Martha. The other common question we're getting is, and I get this one daily, is should we be advancing the interval for our 5 to 11-year-olds? As you know, NACI's recommendation of 8 weeks has been the focus. And then with the schools coming back, there's been a push to get them done earlier. Any thoughts on that? So
what we do know is that the first dose of the vaccine already gives excellent protection, like well over 90%. And this was actually from the Pfizer study, the original study on children, both younger and the teens. And we've certainly seen that sustained in clinical practice. So when we think of the interval between boosters, there's a period where you have to allow the immune system, there's a certain degree of maturation in terms of the body producing the original antibodies, developing some cell-mediated immunity. So when you give the booster, you get the best response. And there's pretty clear evidence worldwide, certainly in adults and in older individuals, that the 8-week interval provided a much more sustained response. And so when the people who are more likely to have the breakthrough infections or to see the waning antibodies were the shorter interval. So I personally, I think NACI got it right. NACI, for those who don't know, is the National Advisory Committee on Immunizations. These are, national experts. They review the data. They have a very clear, in-depth understanding of how vaccines work and how to recommend them. And so, knowing that the main reason for vaccinating is to protect the person being vaccinated, children, to start with, are very low risk. So we're going from a very low risk to a very low risk with the vaccines, to an even lower risk. The first dose already gives that. I guess for me, if you want the biggest bang for your buck, it's actually doing the 8 weeks, because that seems to really set the immune system the best. The other thing that we did that has been seen is that with the longer interval, there were it was less likely to see some of the adverse events that were being described, and certainly in teenagers and people in their 20s, particularly men. We have seen increased cases of myocarditis post-vaccine. The reports of this happening in the younger kids, there haven't been as many, which is, I think, what people were expecting, simply because of what we see with myocarditis in other situations. Not that there have been none, but it's been the safety signals are very reassuring. Nevertheless, having said that, I find myself thinking, I don't want to invent stuff. I think we should actually follow what our National Advisory Committee Immunizations recommended. There are, everything about the vaccines that we've seen is that the children are tolerating them really well. We're not seeing a lot of adverse effects. On the other hand, we're still learning how long they'll be effective in the kids. We haven't been vaccinating kids long enough to answer that definitively. We certainly saw that waning of immunity in older people, which is why the whole conversation of boosters. And so my comfort level with vaccines is to have that risk-benefit conversation, but I actually have a lot of respect for NACI and for the work they do. And I didn't feel like second-guessing them. I didn't think it was necessary. I don't think it was necessary. I think the recommendations were spot on, that the risk of COVID is low, very low. There are some kids who definitely should be vaccinated. Any other child where they wish to be vaccinated should be vaccinated. But at that level, we respect the family's choices. I do not believe, for example, it should be mandated for young children, again, because of the risk-benefit conversation about it in this age group. And also because everything is pointing to them being safe, but we are still collecting that data. I would also remind parents that we are vaccinating. We are vaccinating children in Canada, and so far so good. As I say, everything is pointing to a really good safety profile. But this is not universal. The recommendations are different in other countries, and in most of Europe, it's approved for 5 to 11, recommended for high-risk kids, recommended for kids where there's a high-risk adult, and optional for everybody else. And with the 8-week interval. And so again, I don't think Ontario needs to create its own unique rules where we have strong recommendations from NACI and we've got excellent recommendations from the European CDC. We can learn all these things and you know what, just do it properly.
Amen. Yeah. Follow what the experts are saying. I think it's, that's an important thing to mention. What about long COVID? This is another one that I get. Long COVID, or also might as well talk about MISC as well.
Yeah.
Are you concerned that it's like, that's one of the arguments people will mention is like, yeah, maybe kids do well, fine, but I don't want my kid getting long COVID. I don't want my kid getting MISC. What are your thoughts on this?
So I'm going to talk about the MISC. So MISC is multi-inflammatory syndrome of children. It's a post-infectious phenomenon that we have seen after COVID. It usually happens, within 4 weeks. It's actually quite interesting because anecdotally, in here as well as Europe and the US, we're seeing way less post-Delta and post-Omicron, and I don't think we know why yet. But that sort of, we're learning about that. But it was like, wait, we're still seeing a few cases, but it was almost like it went away for a while. It's quite rare, and it's one of these post-infectious phenomena that sometimes are seen, and we know that infections, that is not uncommon to get post-infectious phenomena. And I guess you get a huge wave of anything going through a population, you're going to see a wave of post-infectious syndromes. So the vaccines do reduce the risk of this. Whether it makes it go to zero, we're not sure, but it certainly does reduce the risk of the post-infectious MIS-C. Long COVID is, again, I'm going to call it post-infectious syndrome. There are some post-infectious syndromes that are really well recognized. We all know that any virus, any infection can potentially trigger one of these things. Guillain-Barré syndrome is one that we know can be triggered by infections. There's a condition called ADEM. There's for post-bacterial, post-streptococcal conditions. So, I mean, post-infectious syndromes are not unknown. We see them after influenza. We see them after enterovirus. We see them after mycoplasma. So this is a well-described thing that can happen, and it's not unique to COVID. The question is it more common with COVID? And the answer is no. There's a lot of fear. There's a lot of what I'm going to call frank misinformation out there. I mean, I heard somebody saying that 35% of kids are going to get long COVID. I mean, I'm sorry, but that's nonsense, and it's misinformation. There are now 3 really good studies that have been done, and one a systematic review in the Pediatric Infectious Disease Journal, where they've actually looked at that. You need to have a case definition, and you need to look at kids who've had confirmed COVID and kids who have not had COVID, because self-reported, a lot of kids feel lousy right now. We've done that to them with all of the restrictions that have been put on them throughout the pandemic. But what we saw and what we've seen is when you actually do a systematic study and you have proper confirmed case COVID and proper case controls with no COVID, what you don't see is much difference at all in post-infectious syndromes, with the vast majority of symptoms gone by the 12-week mark. Are there some post-infectious syndromes? Yes. Is this a reason to be scared to have your child go to school? No, it is not. You didn't ask me about this, but I'm going to just touch on this quickly.
Do it.
Misinformation. There's a lot of misinformation minimizing stuff, saying the vaccines don't work. There's misinformation about, for a while, like 5G transmitters and who knows what. But there's also misinformation on the other side. I'm going to call it I don't know what the term is, COVID maximizers. But honestly, the misinformation about the risks and the threats and how dire it all is, and that the only way you're going to survive this is if you do all this nonsense, that's also misinformation. And we actually should be calling that out. When people are saying threatening, somewhat hysterical things that bear no relation to the clinical experience, is not based on what any of the pediatricians are saying. And we're also scratching our heads thinking, where did that come from? That's also misinformation. And I actually think it's time that we start calling people out. If you're going to start claiming that this many people are going to have a problem, well, I'm sorry, show me the study. Show me where that data comes from. If you're going to claim that people have to do all this stuff to keep themselves safe, like really? You're telling me that you've had 3 doses of a vaccine, that you yourself have elected to wear an N95, but you still won't let anybody else around you? Like what? At some point, we have to take a step back and say, is this actually make sense? Or do we have people at the other extreme, the 2 extremes of misinformation? Can we actually sort of meet in the middle and acknowledge that there is a middle ground? There is a balance that we could reach. We can totally acknowledge COVID. We can totally acknowledge who's at risk and the role of the vaccines. And we can also acknowledge there's collateral damage. And these are not mutually exclusive positions.
Oh man, I'm so glad you brought that up.
Sorry, I got on a rant there. No,
it's so good though, because part of this is like the dialogue is not safe. I had someone comment to me on Twitter. Vinay Prasad just recently put out a Twitter post talking about how we really should have done a better job evaluating some of our interventions, like, whether it's lockdown, masking, all this stuff. Yeah. And I retweeted it, and some people were like, how can you promote this guy's activity, or like this guy or whatever? And I'm like, what? First of all, I love Vinay. Okay, so I'll go to bat for Vinay. Second, it's not about the person, it's the content. Let's stop trying to be all tribal. Let's stop, focus. like the value. The argument should be in the value. What are you trying to achieve? As opposed to like who said it, what do they represent? Like this is why we're where we are, because we're being so tribalistic, because we're so black and white in our thinking. Okay, like we need to move. Like we need to be better.
I said something about Florida. I said, Florida did something really well. And before I could even say that, I was lambasted because I was talking about Florida because they're Republican. I'm going, whoa. I'm not talking about politics. I'm saying they focused in on early treatment quickly. They set up a lot of monoclonal antibody clinics very quickly. This was well done. It has nothing to do with politics. It has nothing to do with whether what you believe in or not believe in. It's just a fact. They did this really well. And by focusing in so much on early treatment for people who got COVID, they prevented a lot of hospitalizations. I'm not going to talk about politics. I'm just saying it's a good thing. And we were kind of behind the eight ball doing that. And so when I compliment Florida on something, I'm thinking this isn't a political stance. I'm going, oh my goodness, I'm just making an observation that early treatment is a good thing.
Yeah, 100%. And I hate to say it,
they weren't willing to take it because it was Florida.
Oh man, and I hate to say it, but our physician colleagues have been the worst when it comes to this. Oh, you mentioned Florida, you mentioned Texas, you mentioned Sweden in a sentence. Holy cow, you're anti-vax. Like, come on.
Yeah,
I got one more main question for you. Boosters amongst our 12 and 17-year-olds. How do you feel about that? Because there's a push for it in some places at this stage of the pandemic. I
don't think we have any evidence whatsoever it's necessary. I think, when we think of giving boosters, that the recommendation should be based on the clinical rationale. And what we have seen in the studies that look at boosters is that where we see a good clinical impact is actually in the over 70, over 60, but definitely over 70 age group. So I really think if you're going to say, what's the point, what's the medical indication for doing this and the timing of it? These are really important questions. And for me, again, I'm just going to say it's nothing to do with politics, but I'm saying if our objective, which I think is what the objective should be, is to minimize the number of people that get severely sick, then we zero in on the group that most benefit from that. Because our teenagers with the 2 doses have shown every evidence of having excellent protection. We don't see a waning immunity. We don't see an increase in hospitalizations after 2 doses. They're fine. Whereas with seniors, we were starting to see a waning immunity and an increased risk of being hospitalized, and giving that group a booster has helped and sort of done what it's supposed to do, boost their immune system. And so if we're going to recommend a booster, then it really, I think, should be based on a determined clinical outcome and a rationale. The other thing about a booster, and again, this is a personal opinion, is that I think the timing is very important. So you want to do it when you've got that proper sort of maturation of the immune system, so that when you give it, it actually has a good impact in terms of consolidating or boosting that immunity. But the other thing I'm going to ask, and this is a bit provocative, is if we're starting to see a seasonality to COVID, which is what we see with all of the coronaviruses, and we're going to start to see seasonal variations, then do we boost now as the wave is on its way down? And we probably won't see any cases in the summer because that's what we've seen in the last 2 years. And so the chances are pretty good that we're going to drop and have a hiatus. And do we then wait and time a booster for the next wave, as we do, say, with influenza vaccines, where we tend to give them in October when we know that we're going to be hit, sometime November to January? And so I think that these are reasonable questions. I am obviously very much in favor of vaccines. I mean, I'm an infectious disease doctor, but that doesn't mean I'm in favor of just willy-nilly doing this without any evidence or thoughtful discussion about, if we're going to do it, what's the best time? What are we aiming to achieve? What's the clinical outcome? And what's the best timing for it? And it may well be that we end up with a vaccine similar to influenza, where it's tweaked every year for whatever the circulating strain is. and it's given just before we get away. I don't know. I can't predict the future. But asking these questions is not unreasonable. Asking these questions is saying, look, we've got a great tool. This tool of vaccinating people, particularly our vulnerable adults, has done a phenomenal job keeping people out of hospital. But can we fine tune it now? We don't have to maybe necessarily boost everybody all at once in a panic because we've got an Omicron wave. Maybe the best thing would be zero in on the people who are landing in hospital, because that's where we want our intervention to be. We want to minimize the risk of people landing in hospital. And really, I mean, that should be our aim. And if that's our aim, then the biggest impact is vaccinating 70 plus, and then any adult who's at high risk landing in hospital, and then people with high risk conditions. Because if you've got a healthy 17-year-old who would never have landed in hospital in the first place, the booster may or may not make any difference. Well, it won't make any difference because they weren't going to land in hospital in the first place. And we have to be very cognizant when we talk about this as well. That's the primary benefit. It's disappointing, but we're not seeing great prevention of transmission. There may be some reduction after the booster, but again, is that enough to warrant doing it to everybody, or is it better to focus all of our attentions and energies on the group that most benefits? These are questions, but when people ask these questions, I don't think they should be shot down or be given labels. I think it's, yes, we think the vaccines are great, and let's fine tune how we're using them now.
Absolutely. I mean, the great points. If you're going to be boostering kids, are you reducing their risk of being hospitalized? Are you reducing their risk of transmission? And is it safe? Like, so I just want it to be data-driven decisions. You know what I'm saying?
Yeah.
Like, not just willy-nilly. Yeah.
Yeah, it's early. And it is not, again, mutually exclusive. A person can be absolutely in favor of the vaccines, but also pragmatically saying, you know what, we've only been vaccinating kids since October, November, teenagers since the summer. Everything we say so far is very reassuring, but yes, we have seen some adverse events in some cases. Yes, we're learning about the frequency of it. Yes, we're learning about how long lasting this is. And kids have very robust immune systems, a lot, stronger, is more reactive in a lot of ways. And we may discover that they don't need to be boosted anywhere to the same extent as a 70-year-old. And that's also okay. It's not in any way putting down the vaccines. It's saying, we've done an amazing job rolling it out. We've fundamentally changed the face of what we're dealing with. And now we have the luxury and the opportunity to fine tune how we're going to use this and make sure that we vaccinate each age as they need, acknowledging their risk and acknowledging how their immune system works.
Absolutely. And the fact that a lot of us are going to be exposed to Omicron and have a hybrid infection will also play into what the future looks like. It's going to be a very interesting 2022, I think.
And that's another question we're still not talking about in here is, what do we do with people who've had COVID and recovered?
Yeah.
Because in as I say, in Germany, for example, their very strict vaccine passport is you're vaccinated or you've recovered, and they count them as equivalent. And I actually think we should be studying this. We should be looking at how long does the immunity post-infection last? How good is it? If we're going to vaccinate post-infection, again, you should be treating it as a booster and figuring out when is the best time to do that. And even asking, do they need it? How many people have recovered have actually had breakthrough infections compared to people who are vaccinated? These are not anti-vaccine messages. These are pragmatic academic questions to ask, because we are learning a lot, and we've seen a lot of studies coming out that show that people who have recovered from COVID have a very good immune response, and we shouldn't pretend that's not happening. We should recognize it, learn from it, and figure out how to work with that.
100%. It's one of the many questions I've had regarding COVID is not acknowledging it, while other parts of the world have done so. Not doing seroprevalence studies in our own country, like how many people have already had COVID and maybe not known it or maybe not get tested, just to see how we're doing from a broader perspective. But so many questions. I'm just going to answer one quick question about when you talked about Florida and was talking about early treatments. Early treatments are such like monoclonal antibodies. So basically it's when you are diagnosed with COVID and then offered a treatment to reduce your risk of being hospitalized or dying. So monoclonal antibodies you could get here in Ontario, very specific criteria based on availability. So that's one. The oral Pfizer antiviral is not available yet in Canada, but I'm sure we're just anytime now we'll hear from Health Canada. There's fluvoxamine, an antidepressant that's had a positive study in reducing hospitalizations.
Repurposed drug.
5-day treatment, I believe. So there's stuff out there.
Inhaled budesonide.
Yeah, that I don't think it's been RCT'd or.
No, but it seems to be showing pretty good. Yeah. And and it's very safe, well used. I mean,
no, it's and so this is also part of the future moving forward, I think. So listen, Martha, I just want to give a mad props, a super thank you, because I get emotional thinking about this, but I don't know if people fully understand how much of a hero Martha is in terms of advocating for our kids, because I felt it firsthand. Number one, thank you for all the love. I think you've gotten that too, Martha, throughout this country, people reaching out saying thank you for the advocacy, but it's not easy, people. Like I know it firsthand what Martha's going through about the professional threats, the emails, the social media threats. It's hard. It's hard on just as a human being to be, put under that kind of scrutiny.
Yeah. And I never expected advocating for kids would ever be thought of as controversial.
I know, but it's, and I'm saying there's very few of us doing this. And this is why I want to thank you, because it gives me, so I'm getting verklempt. I didn't think I would. It gives me strength seeing you do what you do. And I'm going to continue to do it based on,
and honestly, the more voices that speak out, the better off for our kids.
100%. The other thing I will say is for the teachers out there, this is all about the teachers and the kids. And this is one thing I heard on a previous podcast, which I think was brilliant. If we're going to create some of this change, I'm always going to make myself available. You have a group of teachers, you have a group of parents that want to ask all the COVID questions you want. I'll be as honest as possible. If I don't know, I'll divert it to someone that does know. But so from someone that has seen COVID himself, that is also recognize the risk, the reason why have no worries about my kids going to school. But if you want that availability, I will create time so that we could appease this, because this is how I think we'll create some more change.
I've actually offered that before, and I'll reiterate that as well. Any group that's ever asked me to speak, if I'm at all able to, I will. Whether it be Zoom, I actually am happy to meet people in person because, as I say, I think the vaccines work. And but I've always also said that anybody at all who wants to have questions answered or run scenarios, I've always also said I'd be more than happy to do it.
Absolutely. Once again, Martha, super informative. I think this might surpass our other episode. You might be number one and number two. Who knows? Either way, it's glorious. Thank you so much.
And look, happy school for everybody.
Happy school.